The purpose of this session, which goes until our morning tea at 11, and I'll probably finish just a tiny bit before that, is to really look at, is there really a duty for multidisciplinary teams to help patients to stop smoking? Certainly, Dr. Warren, I think, has spelled out that duty in no uncertain terms, but do we really think there is a duty to do that? And what if patients say, I've got cancer anyway, it'll be just so stressful for me to stop? You know, what do we say to that? And then, if we are keen to embrace the imperative challenge of Dr. Warren, what are examples of great strategies and actions that are showing some sign of effectiveness? And then most importantly, I guess, what are the barriers to getting engaged in this and helping people to stop? I feel like finding out the clinical background of people, because this is a shocking assertion, but I think health makes defence look like a flat organisation. What I mean by that is that there is a strict hierarchy, and often unless you convince doctors to support your actions, you may not be able to get change. And there was only a few doctors here. Hand up if you're a nurse. Thank you very much and welcome. Hand up if you're in allied health. Thank you. Hand up if you're a policy person in some form of agency. Thank you. And hand up if you're a funder of any kind. And we'd all like to have morning tea with you. No. Thank you, a funder over here. Thank you very much. And, I had another, a non-government organisation who's active in this area. Thank you so much. And if you're from a patient or family support group or patient-family representative, thank you very much. Welcome. Have I forgotten someone who would like to yell out at me? Researchers. If you're involved in research, thank you very much. Thank you. What was the other one? Administrators, so hospital administrators of any kind. Or primary health network. Primary health network, put up your hand, because that's important. I think in this area. So that just gives the panel a little bit of a sense. So, Sanchia, can I come to you? Just first of all, is it a duty of clinicians? It's on, evidently, but nice and close to your mouth, guys. Almost lick it.
Okay.
Yeah, you know I'm madly into volume. Is it a duty? Is this the moral imperative of America? They're a bit more Christian over there. We're a bit more secular over here. We can sleep at night if there's 5 of them. We don't talk to them about smoking. Is there really a duty to address it as part of acute treatment?
Absolutely. And I think one of the most powerful things was what Graham said at the end around number needed to treat. If we had a drug that powerful, we would all be clamouring up to the PBAC and lobbying for that drug to be available. This is more powerful in terms of cancer outcomes than any other thing we have. And of course it's a moral obligation.
And can people unpack their own acronyms? Pharmaceutical Benefit Advisory Committee? Yeah. So the mob you have to convince to get a drug on the PBS.
Yeah, we now pay around $200 million a year to treat melanoma, the vast majority of that being for the 400 patients that are on targeted therapies, and yet we don't spend in our hospitals 1 FTE to support patients to stop smoking.
Can you just explain what Cancer Council Australia is and how it fits in with the networks of cancer councils? Again, for Dr. Warren. And so explain your network, and then what's your role in cancer patient smoking cessation?
So Cancer Council Australia is the peak body for the Federation of Cancer Councils around Australia. We're a non-government organisation. From Cancer Council Australia's specific perspective, we were the first to raise the issue of things like plain packaging. We've been the advocates for tobacco excise. Most of the beginning modelling for that and its potential impact has come from cancer councils. Cancer Council Victoria have been the architects of understanding the behavioural impact of things like plain packaging, tobacco excise, out-of-sight sales, so a really critical role in this. We, as Cancer Council Australia, haven't had a role previously in health services and the delivery of patient treatments, but our new strategic plan will start to align advocacy across states and territories with federal government, and so we see that we have a tremendous opportunity to advocate across the nation for the kinds of wonderful work that's happening in places like Murrumbidgee to be part of normalised service delivery, not just for cancer, but for all people who smoke who attend health services.
We saw a film from Murrumbidgee Local Health District, but quite a number of people have come since that film was shown. So in a nutshell, what did you see in the Murrumbidgee project that you think should be happening everywhere?
I think what I saw was that smoking is the biggest single issue facing health outcomes for people in Australia, and that health services provide a window at the point of motivation for patients to quit, and that it is the obligation of every single individual in that health district to take the opportunity to at least ask and refer.
You're concerned about equity. What do you see as the equity issue if we come now directly to that question of a patient with a cancer diagnosis?
So we know, particularly from research in New South Wales that's published today, that we have trebled the gap in cancer mortality between those of low socioeconomic status and those of high socioeconomic status. If you look at that nationally, there's about a 30% higher age standardised mortality rate for low SES, and we know that smoking rates are higher. In some analysis that David Whiteman has done from QI, from the Queensland Institute for Medical Research, that equates to about 13% of cancer mortality could be improved just by addressing socioeconomic disadvantage, and around 40% of that is directly linked to tobacco use. So it's a massive, massive part of the cancer outcome inequities in our country.
So I'm a clinician. There's some form of organised system in my multidisciplinary cancer team to enable me to ask some questions, identify people who need support, as Dr. Warrens has suggested, and refer them. When that lower socioeconomic person gets to the point of referral, what additional barriers will they face because of their poverty?
So they'll face issues around the affordability of nicotine replacement. They'll face the fact that their families also all smoke, and that this becomes a really difficult thing to do on their own. And so they face that social imperative. They may also have lower health literacy and capacity to access the services and to engage with them. They're likely to work in environments that also where smoking rates are significantly higher. And so the whole pressures to smoke, it may also be that it's the one thing they see as a pleasure. They may also see that it's the one thing that helps them manage the stress and obligations that they have that they really do face far more difficulties socially.
And so what are the policies you're advocating and the systems you're wanting to see in both hospital and primary health clinical settings to address that? Like, what's got to happen to give them a fighting chance of survival?
So I think we could see a number of advocacy agendas. I was sitting with Paul over there, arising just from Graham's talk. The first would be, I think we have an advocacy role in ensuring that tobacco use is a mandatory data item, both at the point of clinical care, but also particularly in clinical trials. I think we can advocate to ensure that for people who are facing an illness such as cancer, that nicotine replacement therapy is free, that we don't see those kinds of difficulties challenging use, but that we encourage every single health service to have a framework and a policy, a bit like Murrumbidgee's, that actually see this as a whole of health issue that needs to be addressed.
I'm putting a submission to Treasury, and in a slightly unprofessional but frank way, one of the people says, well, they could afford the fags. Why do we have to give them free nicotine replacement?
So one of the things that you might want to say is that one of the biggest pieces of income for federal treasury is tobacco excise. Australia will, within the next 5 years, become the one country in the world where the tobacco excise meets the WHO recommendations of 70% of every packet. It's time for us to put some of that money to work for people who have been affected by tobacco addiction.
Look, thank you so much.
Can I say one positive thing first?
No, please.
I think the other really important thing is that Australia's come such a long way. In the most recent survey we've done on youth smoking, more than 80% of our kids have never touched a cigarette. This is 14 to 17-year-olds. More than 90% of them have never had more than 100 cigarettes, and only 2% of them are regular smokers. Let's create the environment that sees that continue.
And before I let you go, the Indigenous smoking numbers that we've heard there, obviously catastrophic. What's happening in the Cancer Council world in relation to that target group, if I could use that expression?
So it's an area that we obviously feel very passionately about. We applaud the federal government for the work that they're doing in providing specific incentives for programs to work with Indigenous communities around tobacco. We see that we need to do more in coming together with Indigenous organisations, and we will do that through the National Indigenous Cancer Network, where we try and actually bring the peak bodies together to tackle some of these issues, because what we've learnt, I think, is that we can't do it alone, and neither can the Indigenous organisations do it alone, but we need to really come together and see this as a community issue that we have to help address.
Just before I go on, has anyone got experience or an example of an Indigenous-focused smoking cessation program that you think is doing interesting work, or any other example of good work? I just want to share things from the audience. Thanks a lot, guys. And guys, don't hesitate. Involve. Imagine yourself in a little television chat show where speaking is so important. And if you could just introduce yourself. Thank you.
So I'm Scott Walsberger. I'm the Tobacco Control Manager at Cancer Council New South Wales. So just to highlight some of the work that we do in partnership with Aboriginal communities at Cancer Council New South Wales is through our Tackling Tobacco program, where we try to encourage organizational change to change policies and practices and systems so that we do get smoking cessation as part of normal practice within organizations. And last year we worked with 8 Aboriginal medical services, and this year we're continuing to work with them and an additional 4 in helping them to develop programs and change plans that are appropriate and specific to their local communities.
When you were listening to Dr. Warren, what were some of the thoughts going through your brain?
I think there's so much that we can do, and I think what strikes me in these conversations is that the problems are the same, I think, regardless of whether we're looking at clinical practice or community services, or Aboriginal services. And community services and Aboriginal services are the areas that we focus on at Cancer Council New South Wales. But what we see is that people think that it needs to be addressed, but they see that it's someone else's problem. That they see that there's lack of training, there's lack of policies, there's lack of systems to help make this easy and make it systematic. And those are the things, I think, those systems change that we need to really start getting all of our organizations to change and make this everybody's business, regardless of what organization you work in or what type of role you play in that organization.
Thank you so much. Would you give him the clap of encouragement? Could Professor Jeff Delaney take the microphone? I'll just introduce Jeff. Jeff Delaney is a staff specialist in radiation oncology at Liverpool and Campbelltown hospitals, and this is sort of southwest Sydney for our American visitor, and the Director of Cancer Services for Southwest Sydney Local Health District. Just before I ask you a question, what's going through your mind at the moment? They're saying we need to have an easy referral system. It should be integrated into cancer services, that the most effective thing you can do is to help someone stop smoking to help them live. What's going through your head, Jeff?
So I've got 2 initial thoughts. The first,
right in the top, yeah.
The first is that I think we've always had that duty to refer, and we're not referring. So we need to look at different models. And that's been shown to also be the case for other aspects of patient care, where if we rely on the clinicians to refer a patient, it doesn't happen. So the other example I'll give you is anxious patients and referring onto a psycho-oncology pathway. One of the things going through my mind at the moment is that we're currently trying to electronically screen patients for anxiety and automate referral. So essentially we're taking the responsibility of referral away from the clinicians and making it a systematic approach to nicotine replacement. So you make the response to the patient as a matter of purpose. Our department always refers smokers to a smoking cessation problem, to a smoking cessation service, because we believe that you'll have a better outcome by doing that. And we use the teachable moment when the patients are anxious about their cancer to teach them the importance of nicotine replacement or smoking cessation, but we then pass it on to the experts. I'm certainly not an expert in nicotine replacement. I don't intend to keep up with the literature about whether it's better to do nicotine replacement or counselling or hypnotherapy or acupuncture. I don't know the data well enough. I don't know how to decide between those various different interventions, and I have no intention to learn, because I've got enough to do trying to keep up with the literature in radiation oncology.
But what you've just described is what you want to happen. It's not what's happening now.
That's correct, and it's not happening now. I agree with that.
And so what are the barriers to that change happening? Because you know how you spoke then from the heart, which is great. I'm just too busy keeping up with my radiation oncology reading. And what from the charts in Dr. Warren's presentation, probably the nurses, the speech pathologists, the dietitians, the medical oncologists, the radiation therapists, I'll just go all down the list, they're all feeling they're overloaded, so it's not my job. So you're a systems man, you're the head of it. What would you have to do to make that change happen? And what will be the barriers to you delivering?
So I've been thinking about that, Julie. The one comment I'll make, and I really enjoyed Dr. Warren's talk, and it obviously focused on the cancer outcomes because it's a cancer conference. But there are two other aspects about smoking that impact on the broader population in a hospital, and that is that there are many other diseases that are made worse by smoking. And secondly, post-operative recovery from anaesthetic is worse from smokers as well. So it's the local health district's interest to set something up that is centralised. So I'm not sure that cancer specifically should set up a multidisciplinary smoking cessation program. I think what I need to do is go back to my local health district and my administrators and some of my colleagues in other chronic illness and come up with a centralised multidisciplinary model where we know where we can refer patients and they'll get evidence-based expert care in smoking cessation.
He wants the cardiac people or diabetes to do it. Why should cancer do it?
Well, I think...
I'm asking Dr. Warren, how do you respond to that? I mean, when I hear that, and I'll come back to you, obviously, Dr. Delaney, but is everybody coordinates it. And what worries me as a patient is once everybody coordinates it, is anybody responsible?
So
really close to your mouth.
there's two things.
Really close.
Is this close enough?
Yeah. No,
This makes me
seriously.
sound-
And see if you can hear your own voice. It's working. You know, radiation impairs hearing.
But I have a loud mouth. There's two things.
No, close. Seriously. Yeah.
Two things that I wanted to say. One, we did develop this opt-out approach for all of MUSC, and we've actually reduced hospitalization rates, readmission rates, and the cost of readmission. And the model, exactly as you said, fits not only cancer, but what I just discussed here, the opt-out type of approach with this type system process is really very well designed for chronic disease management. I will note that there are some differences that should be considered in a single visit per year acute care model, because it's a little more difficult to emphasize over and over the importance. Now, the second part of this, I really wanted to go back to what Dr. Delaney said. What he said about referral, I want you to realize what we do. We have to use a piece of paper. We have an electronic medical record. We have to use a piece of paper for assessment, and then in that assessment, we have an annotated response system where legitimately a person comes in to scheduling or to registration, sees, fills out the paper, the nurse looks at the paper, it's color-coded, and the referral goes off to cessation before they even see the nurse. They don't see the physician, they don't see the resident or PA or NP or anyone. The referral is off before they see any clinician. And taking the decision process out of the hands of the clinicians, I can't emphasize enough how much homogeneity you will get and how much you will improve by just using data. Yes, use tobacco, the referral is going off, now you'll go see the physician. And it works very, very well, not only in the oncology setting, but even in a hospital-based setting. You will have pockets of resistance. That's inevitable. But the mechanism that you just described, I just want to make sure you all realize that's what we do. That is the identification and referral mechanism.
Now, Dr. Warren, I'm a very persistent terrier-like person. When you put me in a linac, I will obey you. And what I ask is to put it close to your mouth, because trust me, it's so important that people hear. And down here, see how it's really different? And up here, look how beautiful it is. Trust me, because we want to hear every word you say. Jeff, that's a really good idea. Why hasn't it already happened? Is this all news to you? You didn't know smoking was so dangerous?
Sorry, Julie, I've been busy, but I'll put it on my list of things to do. I think it is important in all seriousness.
But you know, I didn't mean to do that a facetious or a personal question. It's more interesting, isn't it? If the pay dirt is so powerful, why haven't we got sophisticated, multidisciplinary, high-profile smoking cessation teams in every acute setting with referral points in the primary health network?
It's a good question. I don't have the answer other than we're working in a complex system, and up till now people have not considered it their responsibility.
See, that's it. How interesting. This is Associate Professor Philip Beale, a medical oncologist, Director of Cancer Services and Director of Palliative Care, Sydney Local Health District, with roles at Concord Hospital, RPA, Royal Prince Alfred and Chris O'Brien Lifehouse. Did you want to answer the question why we haven't done it?
Well, look, I think what Jeff was referring to and what we have, the problem is that the organisation does require a lot of that process of getting all of those people together and being able to have those referral pathways, have everyone on board, and I think those things are not happening in that regard. And we, as Jeff says, there's been a lot of focus on, just for example, MDTs, for being able to make management decisions, that we get consensus, that we get the recording, and that we get those processes about management and treatment decisions. And so that has not included smoking cessation, I think, in that traditional model, because it's still about saying, well, when are we going to give the radiation? We're going to give before or after the surgery? Are we going to give the chemotherapy before or after the surgery? What will be the doses, and how are we going to manage those patients? And deciding those things in that multidisciplinary meeting has been a focus, rather than the about smoking cessation, for example. And then in addition to that, I think there is, as Jeff says, that there's 5 or 6 or 7 or 8 or 9, 10 other things that you might say to that patient about, well, we need to look about and identify your needs in terms of anxiety and depression, about your exercise capacity, about your diet, your diet and how you eat and the impact of that. And so there's just this now increasingly long list of the best care. And that best care means that you really need to have either very good systems, and I think that I think that the message that I got out of the talk by Dr. Warren is to say, exactly, can we work on those systems? But it does require money, it does require resources, and it does require organisation, and they're not straightforward.
Funnily enough, money and organisation, it's the need for different departments within the hospital to collaborate that worries me with Jeff's model. Because don't you all have trouble collaborating? Go. You know what I mean. You're all different provinces in the Roman Empire, and there isn't a clear emperor anymore, is there?
Yes, it is a bit like herding cats. That's true. The one thing I'd say though is that a lot of the economic argument, you don't see immediate return on investment. So a lot of management in hospitals is about the bottom line this year. We're going to come in budget this year. And that return on investment is a long way down the track. And it's about trying to reframe that economic argument to our leaders in order to get them to facilitate this.
I just want him to listen, because I might come to you for a response. And you won't have heard, because this is an interesting point, yes?
So the administrators aren't necessarily focused as their top priority return on investment when the return is actually going to happen down the track. And I think it's about framing the economic argument in the correct way and convincing the leadership to facilitate the multidisciplinary collaboration that would be required to do this.
But aren't you the leadership?
Oh yes, I need to go there with a plan, but I also need other leaders that I have little or no influence over to also be at the table.
Just give a microphone to Sanchia, and then I'll come to this lady here.
probably hand it straight to Graham, because what I was actually asking was how did you fund or how did you measure the impact of the reduced hospitalisation? Because actually in a fee-for-service model, it's the having more hospitalisations is better for fees for doctors and others. In a public sector, in the Australian context, it's better for the hospitals, but in a private insurance sector, it's better for the payers. So it's a complex issue.
Before you go to Dr. Warren, could you just pop it back for a sec, please? Are you saying that there's a financial incentive to keep us coming back in the public system, and therefore, from a budgetary annual point of view that Jeff's just raised, he was basically saying there isn't an immediate economic benefit to getting people to stop smoking, and I was wondering if you would like to challenge that. But are you saying that the economic drivers are heading in the wrong direction?
Well, I think we've got to be really careful about the economic drivers, because if you had a health economist who didn't have a soul, actually smoking's really good for health, because for the governments, because you get a lot of excise and tax from smokers and they die quickly. So it's economically, if you're looking at it in pure economics. And so when you start to look at where the savings occur, you have to actually understand some of the perversions of how all that fits together. So even in our private setting, fee-for-service models mean that the more you see the patient in the private sector, the more the doctor earns.
Dr. Warren, if you could comment on that economic issue.
Is this close enough? So I'm going to take a little bit of the burden off your shoulders. 25% of our jobs are because of tobacco. In cancer, we treat patients, 33% of cancers come from essentially tobacco. We have jobs because of tobacco. The second, you will make more money in a fee-for-service or a private model when a patient recurs, has toxicity, or gets admitted to the hospital, because you can bill for their problems. That's the monetary problems that we face on a regular basis. The third thing, there are inflection points in life, and it's kind of interesting. The entire initiative that we developed around automated cessation programs for cancer patients came down really to a 5-minute discussion with a key leader at an institution where I said, please tell me if you are going to support cessation or you are not, and send me the email so I can document either your support or lack of support, and luckily that person supported it. From that, our entire modeling over the past 10 years came out. Cessation, automated referrals, high participation rates, the stuff I talk to you about now. And at the time, I didn't have to justify a financial model to that person. Luckily now we have so much data and so many different programs that have developed out of this that we can show the cost savings. Now in the United States, my job does not depend in any way, shape, or form on cost savings. It depends entirely upon my ability to bill at the front end. The authority that makes a decision on how they want to spend healthcare dollars here is critical. The cost savings in the long term far outweigh, by a log scale, the billable events up front. That has to be realized by the people who are going to pay for this. And I'm not trying to turn cross or otherwise. Functionally speaking, that is exactly the barrier that we face more than anything else. The automation, getting it into clinical care, I agree completely with Dr. Delaney. I actually know a good bit about tobacco, but I send everyone that I have for cessation support, I speak to them about 5 minutes, I send them to our cessation program. There's a burden associated with providing care, and the financial aspects of it are dominating the healthcare delivery market across the entire spectrum of healthcare, including tobacco. So find out, well, this is still being recorded. Maybe I can pull it away from my mouth.
This is being broadcast live to the world.
Excellent. The problem is that in plain terms, the people who are in charge of the overall healthcare system are the ones that are having to pay the money the most for the failure of addressing tobacco, not only in cancer, but in other chronic diseases as well as in risk models. Convincing them that the savings will come is going to be necessary for our implementation and maintenance of a sustainable approach.
Look, thank you. And I just want to, yes, please, a round of applause. I'd just like to welcome, you may have noticed that a blonde woman has joined the panel, and that is Dr. Bronwyn King, a radiation oncologist with the Peter MacCallum Cancer Centre in Melbourne, and the founder of Tobacco Free Portfolio. So welcome. And in essence, what's happened is a a gentleman from the United States has put a powerful case that the single most important thing every member of a cancer team can do is to assist people with a cancer diagnosis to stop smoking, no matter what their health status is. That's the nub of it, and he's put forward some strategies about that. I just want to come to this lady. Do you want to introduce yourself?
Yes, I'm Emily Stone. I'm a clinician, and I wanted to put the voice of the clinician here. And I wanted to thank the panellists and Dr. Warren for an excellent morning so far. Tobacco control and tobacco cessation is clearly very complex. And I do agree that the clinicians have responsibility to help patients stop smoking. I'm at the pointy end. I'm a lung specialist. I work with cancer patients. I work with patients with COPD. And I feel, rightly or wrongly, that I'm in a smoking cessation vacuum. I don't have anywhere to refer my patients. My patients tell me about the private options they explore, and I support them as best as I can in my clinical consultations. So I think at the moment, and I've just been Googling support services for smoking cessation while we've been talking in New South Wales and around Australia, and unless I'm missing something, most of it's online and downloadable documentation. I couldn't find a clinic that I could send my patients to easily, locally, and certainly not a public one. So I try and do my best myself, and because I've had the good fortune to work with tobacco experts over the last few years, I've educated myself in tobacco cessation. I'm not an expert by any means, but I'm doing a lot better than I used to. And I think that the responsibility of cancer health professionals is not taken up by cancer health professionals because they don't feel well trained. And I think we can train ourselves, and at the moment I think we have to train ourselves because there are no other training options. And I think that has to be factored in to this argument, because I think it's going to be quite a long time until we get a good, systematic, government-led approach to smoking cessation in Australia. Clinician-led activity on a day-to-day basis is not the only answer, but I think it has to be part of the answer.
Look, thank you very much. I'm going to take that as a comment, if I may. I want to come to Associate Professor Jared Martin, who's also a radiation oncologist, Director of Research, Department of Radiation Oncology, Calvary Martin, Newcastle, and a visiting medical officer at Genesis Cancer Care at Lake Macquarie Private Hospital, so the public and the private there. I have some questions for you, but first of all, how would you respond to the lung specialist? What's your response to that?
Yeah, well, I think like you, I'm also a clinician, so I don't have the power of
really close to your mouth.
The power of the administrators. So I feel also there's be kind of like the tip of the spear in some respects, and I try to it's like the art of the possible, you know, as a diplomat, you know, like what can you actually do at the shop front level, and I sort of break it up into a couple of pieces, and one is the initial consult where the patient has clearly some degree of vulnerability. And so as a clinician, you obviously have a pastoral role to try to kind of support them through that, but you also have maybe an opportunity when there's these lifestyle measures that you can be trying to address and maybe tip them from that pre-contemplative stage all the way through to actually initiating something to do about it. And I do find at that moment patients often are they're wanting to take some ownership. They're wanting to actually do something other than maybe just plug into a system. And a lot of them, when you dig, the thing that they are doing is something like diet or over-the-counter antioxidants or material they found off the internet. But the answer's often staring them in the face that it can just be the sedentary lifestyle or the smoking or the alcohol. And of course, trying to strip all that down in a short period of time can be challenging. But I think it is our responsibility to maybe pick a battle out of that. And on the smoking side of things, I find that the thing that really tips them in is understanding some sort of mechanism about how that can actually be happening. Because we have the data, but that sort of seems quite remote in a way. If you can make it sort of personal and immediate, I find that sort of often resonates. And the way I spin it with patients is that with radiation in particular, we need oxygen to be in the cells for the radiation to actually have effect. And you know how you get breathless when you're smoking? You know, that's because you have issues with the oxygen getting around. And so in a way, you're kind of running interference on the way that the radiation could be working. And so if you're going to commit the next several weeks of your life and all the toxicities and hassle and logistics that go through the radiation, probably the least thing you could be doing is trying to go through some effort to try to give it the best chance of working. Now, the only trouble is I'm not sure if any of that's true, but it actually sounds like it makes sense, and patients seem to often be able to find that to be a good segue to then, well, what can I do about that? It's hard, for all the reasons we've heard about.
Jared, wasn't the part of the presentation we just heard that, was it a suggestion or is there already evidence that smoking during treatment can lessen the impact of cancer treatment? Wasn't that one of the messages of that presentation?
Yeah, but I find quoting data and 60% relative risk ratio increases and things like that.
No, but you just said, I'm not sure if that's true.
I mean the actual mechanism I was talking about the oxygenation and the effects on the rate on the cellular level. But I think that's because we in some ways hold ourselves up to a very high level of needing to have all this very strong evidence before we wheel it out. But in reality, patients are really just looking for something to that makes sense to actually justify an action. And if it's going to potentially help their treatment, I find it to be a pretty easy sell. I personally use the quit line mainly because it has actually got a little thing down at the bottom where the patient can actually register, or the smoker can register for a callback. But it doesn't actually have to be the smoker who does the registration. You can actually do that for them on their behalf. And it takes about 30 seconds just to scroll down to the bottom of the page and chuck in their mobile phone number and their name, and they want to be called the next day between 8 and 12 or whatever. The only downside I find with that is that it becomes sort of a black hole, and that you never really get any feedback as to the effectiveness of what you've actually achieved from that. Whereas I found other lifestyle measures like with exercise physiologists for sedentary lifestyles and stuff, you do get sort of baseline assessments, progress, and outcome at the end. And I think that would be a great positive reinforcer for clinicians to actually realise that that kind of closes the loop and actually shows that it is actually leading somewhere.
What I'd like to do is ask a question and get a quick response from our three directors, and then I'd like to introduce our next party. And it's this: I basically, as an MC, have been given the imprimatur, the encouragement to sort of build an urgency and motivation to promote the idea that not only do we have a duty as members of multidisciplinary teams dealing with cancer patients to help them stop smoking, but that we're going to leap out there and use whatever networking skills and advocacy skills we have to get good systems that are easy and evidence-based for clinicians to refer their patients to in an automatic way. Is that the nub of it? Oh, well, I reckon that wasn't bad for a nub. What have I missed? Put it close to your mouth.
I think you've hit it in very plain terms. I've had the fortune of working with three people here that I know very well, Emily, Chris, and Bronwyn, who are extraordinarily devoted, driven, nice, kind, evidence-based. They push the limit. I doubt they're the only people here that do that. Did what I say change your mind or your perspective a little bit? If it does, start to apply it. Allow yourself to try and be open to how do we get everyone into this approach or into a cessation approach. Listen to how they behave. How does the program work? Yeah. How do we continue to improve it? Who needs more help? Who needs left? Who does well? It gives the opportunity that if you change a little bit of perspective, now you can start to emphasize the need and design the approaches that are necessary.
Exactly, and that's what I'm heading to, the action point, because with due respect, we've got a lot of nurses and allied health. We've only got a handful of doctors, and you three have each got the word director in your title, and two of them are for cancer services. So, Jeff, obviously I'm trying to really put you on the spot. Remember, this is being broadcast and recorded. What are you going to do after this? Like, how is the action going to happen? Do you have to have funding first? Do we need the minister to do something? How do we make it happen?
So, firstly, the title often doesn't mean very much. Particularly when you don't hold budget. Look, in all seriousness, what am I going to do tomorrow, or not tomorrow, maybe Monday? What am I going to do to change our district? What I'm thinking is that I agreed prior to Dr. Warren's talk about his message. Some of the information I think was particularly useful that I was not aware of, particularly the economic argument. So what I'd like to do is take some of those arguments, show leadership and organise a meeting with the multiple stakeholders, including our chief executive, perhaps with the Chief Cancer Officer in the room as well, and come up with a project. That project, though, if proven, would then be rolled out to be business as usual within the department. I think that's probably the best way to go from just thinking off the top of my head.
And do you link up with diabetes and heart?
Yeah, absolutely.
Yeah,
So the other stakeholders in the room are obviously public health, health promotion, some of the other medical disciplines where smoking is an issue, so surgery, diabetes, renal disease and so forth, cultural stakeholders as well, and come up with a model of a multidisciplinary clinic with appropriate evaluation and, as we've highlighted earlier, appropriate triaging of patients.
Look, thank you very much. And Jared, can I ask you for your thoughts?
Well, even though I've got director in the title, all I direct is research. And I think in a way, although there's important research still going on in this space that we do support, in a way the jury's in about the answers here, and it's really more about bridging the evidence-practice gap. You know, we now have all of this evidence of the harm and even ways of solving the problem. It's now a matter of implementing it in the real world, and this is where the health behaviour sort of people and implementation scientists are much stronger than clinicians who are more have natural strengths often in other areas in the biomedical side of things. And so I think that's probably one of the main areas that we should really be trying to reinforce is working more closely with these psychologists and implementation specialists.
It's just that they have to get the money and the go-ahead, and that's usually from doctors, let's be honest. It's quite interesting. Again, I'm not trying to put you as individuals. You in a sense, are mice, aren't you, in a lab at the moment. In that you're having these natural human responses that, yes, I've got the title director, but in health that's virtually meaningless. It's the people who've got the big bucket of money who've got power. And I keep going back to that slide that that Dr. Warren put up, where everybody agreed we needed to have an area to refer to of expertise and people should take responsibility, but then the huge piece of the pie was someone else should do it, wasn't it? And isn't it partly the problem we've got a really overworked health system and the thought of a whole new initiative is overwhelming? Is that part of what's happening?
Well, I think it's just our natural tendency to play to our strengths. You know, as a radiotherapy specialist, my main strength is the technical aspect of the delivery of high-quality radiotherapy. Smoking cessation, as I guess we've touched on from other clinicians, yes, isn't one of my core high confidence sort of areas. And so, as I say, it's more kind of how do we link up in the various ways that we're trying to talk about here at a systems level to get around that issue.
You're a lung person. What are you doing fiddling with smoking cessation? Just deal with their lungs. So just remind us who you are.
Emily Stone, a beleaguered lung specialist. I've got a project. Why don't we put on the electronic health record Graham's question, when was your last puff? And if it was less than X amount of time, you get a nicotine patch. That could be our start of a smoking cessation, automated smoking cessation program.
Philip Beale, Jeff, do you want to go first quickly and then I'll come to Philip?
Just another very quick point. We've mentioned it a few times, but it hasn't really come up in discussion, the essential role the primary care physician plays in this. And so I think in that stakeholder discussion, one of the issues I think with smoking cessation is follow-up. And I do not think we should be encouraging follow-up in cancer clinics because there's too much follow-up going on already. But we need some way of connecting with the primary physician and an agreement of taking over the responsibility of seeing it through.
I love follow-up as a cancer patient. I feel reassured every time I see you. But anyway, Philip Beale, yes.
Look, I think, like Jeff, we don't have always the influence and control over budgets. But I think what we can do, and what I can do, and I think I am empowered by this meeting in that regard, when we go to the CEO of our district who does hold the money and says, okay, what are you proposing and how can you justify it to me that I will support it? And so obviously there is a clinical outcome here which is about cancer outcomes, and I think that's very powerful. And I think there is a saving of money. So the saving of money that can be shown, even albeit it might be in the medium or medium term rather than the very short term, are the arguments that they will listen to and say, okay, we can see the power of that intervention. And if that intervention is that you have a program or a pathway or a person that then will be able to allow the clinicians who don't have either the skill or the time to be able to do that, is that then you build that in. And whether or not it's on the electronic record, whether or not it is a paper copy, or whether or not it's done in the clinic where you're seeing the patient who's having their radiotherapy or chemotherapy, or you're doing it in some other part of that system. We have a survivorship clinics in our district which are for follow-up, and there probably can be a time where you could reinforce those ideas, rather than the time when you're thinking about the chemotherapy, for example, in my clinic, the short-term, medium and long-term side effects and the outcomes of the cancer. Here is the ideal time maybe that would be allow you to embrace that program.
Philip, I feel like what's being proposed here, though, isn't a person who's just added to a team. This is a multi-departments joining together to have a well-staffed, evidence-based, multidisciplinary team that's about smoking cessation for all the clinicians working with people for whom smoking is deleterious, which is basically everyone. Isn't that the scale of what we're talking about?
But the team is really all of those clinicians who have been involved with patients who have either smoking as causing lung disease, or that the cancer has developed and therefore we want them to stop smoking. So that's us as doctors, but not just doctors, it's nurses and allied health who then understand that, and either that can then work as a team to say, what is our pathway and how can we actually keep reinforcing that and making it sure that it does happen? Because that's the other problem, is that loss of visibility. If you send to the quit line, for example, it's loss of visibility. And if you've got it in your local district where you can get that feedback, well, then you can see that it does...
you're getting impact.
Yes.
Yeah. I'm going to come I'm sorry, I'm going to come here for a question first, Dr. Warren. Do you want to just stand up so people can stare at you because you're the boss? No, it's just it helps people's concentration. This is David Currow. I always hold...
Of course you do, yes. And it's close enough. Look, in response to Emily and to pick up on Jared's important point, we have a statewide infrastructure. It's called Quitline. And together with that, we have the I Can Quit resources, and they're evidence-based. They're making a difference today. They're available. And I agree there isn't a feedback loop, and we can look at putting a feedback loop in place, but it's there. And we don't need to create huge new clinics and lots more people. It's there, it's underutilized. We know that the bottom two quintiles in socioeconomic status preferentially use Quitline over the I Can Quit website, for example. Let's tap into that, let's build on that, rather than say we need to create another infrastructure. If we go back to Dr. Warren's basic point, it is an opt-out program with automatic referral to a telephone-based resource. If that's what we're talking about, we've got it. It's called Quitline.
And what about the suggestion of, thank you, of free access to nicotine supplements for lower socioeconomic groups? Do we have that?
Well, it's already subsidised through the Pharmaceutical Benefits Scheme, and at the end of the day, let's face it, as soon as you start to cut down on your cigarette intake, you are saving substantial money. As Professor Aranda pointed out a few minutes ago, Australia will be the first country to actually achieve 70% excise as recommended in the Framework Convention on Tobacco Control.
Thank you very much. Did you want to say something, Dr. Warren?
So I have a goal this week. We've shown tobacco's bad. We've got Surgeon General's report. We've shown systems process improvement. We've shown mortality improvements. We've estimated costs. I have a goal this week. It's very explicit. At the end of this week, I am hoping that you're going to make the decision that this is important and you're going to task it. Functionally speaking, what you're talking about, the logistics, the individual referrals, the quit lines, development of cessation programs, multidisciplinary, these are weeds. Don't get me wrong, these are all necessary weeds. You have to anchor commitment that this is important, and you have to anchor commitment that we are going to task this in a manner that you can functionally sustain an approach for this across your health system, or not. My goal for this week is that hopefully you decide to do it, because it'll take a while to get it figured out, and you have to be very careful, because there's advantages and disadvantages to phone-based programs, quit lines, online resources, development of individual cessation approaches. These will come out in the discussions. In very plain terms, can I get an idea. Who here is good at tobacco? Not the whole thing, but who here is good at tobacco in some sense?
Tobacco cessation, I assume you mean, do you?
All right. So you've got
There's about
15
6 people in New South Wales. No, 7.
How many people here are clinicians that see patients on a very regular basis? How many times have the two of you all met? Can someone raise their hand if they met 5 times last year? What about twice?
Could I just get a definition of clinician? It includes nurses and allied health?
I'd say, yeah, anyone.
Yeah. How many clinicians are here? See what I
This-
mean? You've got to be careful on the meaning of words.
What I'm getting at is that one person raised their hand for twice in the past year. You have a problem with expertise around tobacco. You have clinicians who know very well what they're doing with clinicians. The two need to meet to work these types of things out. And included, you have a whole series of people. You have intake specialists, IT, you have plus or minus billing, a lot of administration, you have clinicians, but in reality, trying to find a sustainable approach that works would be the next step. Have we convinced you of the need, or have I convinced you of the need, and maybe we, and the ability to task it? By the way, I wanted to point out,
You've got to be quick, sorry.
Never sat on a panel where 3 other radiation oncologists, or I've never had one other radiation oncologist with me on tobacco. This is pretty sweet.
It's very, very exciting. This is a radiation oncology fest because Dr. Bronwyn King is also a radiation oncologist. Just quickly explain tobacco-free portfolios and then say what you want to say.
Well, it ties in very nicely with...
Very close to your mouth.
It ties in very nicely with Dr. Warren's comments then about how clinicians and tobacco control people are often not the same people. And in fact, the story of tobacco-free portfolios was that I was completely a clinician, 100% a clinician. I had no special knowledge of tobacco control, public health, United Nations treaties, international diplomacy, superannuation, finance, economics, or anything. And I accidentally discovered that it was routine that everybody's superannuation funds were investing our money in tobacco. That discovery prompted me to learn about all of those other things. But I had to learn about tobacco control because I wasn't taught it at any point in university. In university, everybody knows tobacco is bad. That's about it. We know it's very, very bad. But I don't think I was ever taught any skills about smoking cessation. And I'm not sure if they're taught now. And certainly Emily's comments really resonated then, which is, look, I, in my career, have had so many teachable moments, really precious moments. As Dr. Martin said, the patient is vulnerable. They want to do whatever they can to get better. And there's this very special moment where a doctor can influence what a patient is going to do. They really rely on you, they care about what you say, and I have felt terribly under-equipped to provide up-to-date evidence-based information, even in preparing for this panel. And it's so sad there's only 6.5 minutes left because my flight was delayed, but in preparing for this panel, I had to reach out to a whole range of people who I'm lucky to have contact with to send me up-to-date information about what are the best strategies, what is
But isn't
the
it
evidence
interesting that you've got to get on a panel to do the Google? That's so fascinating. The reproduction
should
of
also
sound is
say-
in the top, not the side.
Well-
Can I just ask you something? We've got to go to action because of the 6-minute issue. What has to happen to make it easy for you as a radiation oncologist, with all the other things you need to do with that patient, to over the period of time you have contact with them, which will be intense for about a month, and then you'll see them about every 3, every 6. So you've got multiple opportunities over an extended time. What do you need to help them stop smoking?
I mean, my suggestion would be almost like a catch-up education program for clinicians now, so that we can access some kind of workshop or education program. It could even be built into our continuing medical education program. We have to do all sorts of other things to stay registered. As cancer clinicians, tobacco control should be our bread and butter. It wouldn't be difficult to build it into that.
Can I ask you one other thing, because I know you're a money girl. It strikes me that people who really are motivated on this is the insurers. I don't know if we have anyone from the insurance industry, but they want to stop us coming back. There's the only financial incentive for them is to keep us healthy, isn't it? Where we've had a more complex picture with the government and even the health system. So what's the role of insurers to help smoking cessation become bread and butter to every kind of doctor?
Well, actually, many insurers are looking at wellness programs because you're right, it's in their financial interest, apart from it just being the right thing to do, it's in their financial interest to encourage people not to smoke in the first place or to quit smoking. And in fact, in Australia, there's some really interesting financial products that the insurers are bringing out that are almost more akin to health insurers. So, but also in the work of tobacco-free portfolios, engaging with the finance sector, the health insurers are probably the most interested in this work, and they have very clearly distanced themselves one by one from the tobacco industry.
When you go back to Peter Mac to be a radiation oncologist, based on that extra Googling you did prior to this panel, what will you do over the next few months when people come in reeking of tobacco with cancer?
Well, very sadly, it's very important to point out that we have a very big socioeconomic divide in smokers, not just in Australia but around the world. And in fact, clinically, I only work in private, and in private, I see maybe one smoker a year. And in public, you see smokers all the time. It's such a sharp contrast you can't imagine. Also, I think the other thing, I don't know if it has been touched on, is the stigma that many smokers really feel today. They feel very stigmatised, and I think that as a clinician it's really important that we make our patients feel that we're on a team with them, we're on their side. It's not about stigmatising them. We know that most of them started smoking when they were children, and the vast majority of them regret that they did so.
If I could give a patient anecdote, I've had head and neck cancer, and people always say to me, "Did you smoke?" And when I say no, and haven't drunk since the 70s, they look panic-stricken because they want me to have smoked. I say, well, do you feel more compassion for me now because I didn't smoke?
But the reality is they do. People feel more compassionate for people if it's not a tobacco-related illness. That's very clearly shown. It's also in terms of funding. It's why it's so difficult to attract funding for lung cancer, because the community don't feel compassion in the same way that they do for patients with breast cancer.
Is it the community or is it your clinical peers sitting on the funding application committees?
I think it's a very complex issue. I think it's very, very complex. But if I could do one thing for smokers in Australia, it would really be to reach out to them and say, the health community is on your side. We need to work with you to help you quit.
We haven't spoken about it here. Remember I mentioned at the beginning that outside hospitals there's an area where the patients drag their drips to smoke, and there's an area where the clinical staff smoke. And I wonder why we haven't focused on let's get all our colleagues stopping smoking first, because Nicola Roxon sadly couldn't come, but when she had a caesarean, she said she was going to ad-lib this anecdote that, this is obviously some time ago, I think her children are grown up, but she said she was told, we're always happy for the smokers because their babies are smaller. And she was lying there, the pain packaging queen, saying, don't even make a joke about it. Did that anecdote make sense? Yes. Sanchia, what are you thinking, love? What's got to happen to make this happen?
Well, I really would like to pick up on Bronwyn's point about the stigma, because I think there's both stigma and there's nihilism. And I'm reminded of when in New South Wales we did the Listen Out for Lung Cancer campaign and trying to look at early diagnosis, and there were comments that it was a cruel hoax and that all we were doing was actually creating lead time bias and making people know they were dying longer. So I think there's also this one of the barriers to promoting smoking cessation in patients, particularly those with lung cancer, is a belief they're going to die anyway and that they might as well keep that sort of final pleasure. So even though all the evidence for badness. So I think that what we almost have to do is reverse the compassion. We have to feel more compassion for people who are addicted to smoking, because they have been embraced by an industry that creates a product, as Dr. Warren said, with the intention of creating addiction. That is the whole economic model for the industry. It's the same for e-cigarettes. It is about creating you as an addict. And so the compassion should be for the person who is smoking, and we just need to completely reframe our response to make that the way in which we approach everyone who smokes.
App comment.
All right.
if you could implement one change to better deliver smoking cessation support, what would it be and why?
It's got to be unbelievably quick. Jeff, one thing. Grab a microphone. Hit me with it, baby.
I think screening, systematic screening
Why?
of patients.
Why?
To identify those that then need referral to whatever resource you have on smoking cessation.
What would be yours, Bronwyn?
Gosh, I mean, just off the top of my head,
It's got to be close to your mouth.
it would be providing a service for the clinicians to feel, so providing a workshop, once a year workshop, once every 6 month workshop, so that clinicians can tap in to the latest knowledge and be better equipped to help their patients.
Just a second, this man involuntarily wants to speak. What is your one?
I work for a community organisation, so I just want to make a quick comment. I think for any program to be successful, you need to have strong community involvement as a stakeholder as part of developing that program. Because you could, in an office, develop the best possible program, but when you come to deliver on the ground, you'll find that there are so many cultural and linguistic considerations that you haven't made when designing the program, that when trying to deploy it or implement it, you'll find that it's not successful and there's no uptake. So I think getting community organisations on board, giving them the opportunity to have a say in developing those programs, getting buy-in from those that are working on the grassroots levels, and those are the people that are willing and able to push those cessational programs onto the community members.
And your name and where you're from?
Ahmed Malis from the Lebanese Muslim Association. I'm a director at the organisation.
Is there anyone else in the audience bursting to say what has to be said? Wave at me quickly so I can come to you. Yes, everybody breathe in, I'm coming across. Jared, would you give yours while I get across? The single most important thing to happen and why?
Well, I think just amplifying David's point that we already have this great resource of the quit line, and it's really more up to us to be plugging into it more freely.
Okay, so use the quit line. Yes, do you want to introduce yourself?
Hi, I'm Paula. I'm a cancer nurse coordinator for lung cancer in Southeastern Area Health. I think the biggest issue is not opening up the conversation. Yes, there's screening, but there's a lot of doctors or clinicians that don't even ask the question. There's quit line there. Why are we reinventing the wheel? Make the resource available, make the resource known, and that's one more step that we're closer to, I guess, closing the gap.
Thank you so much. Anyone else bursting? I don't want to leave you unburst. Yes. Can I have yours, Philip? What's your signal?
I think I would agree with about the education, but not just to clinicians. I think that's critically important about the existing services and also about the data in the wider forum about tobacco and smoking. But I think also education to the administrators so that we can truly get them engaged in this, in their support, both in systems and in financial terms.
Thank you.
I was just wondering, as a consumer, we spend a lot of time in your offices before we get to see you. So maybe something like up on the screen, there's a lot of how many times did Federer win tennis or whatever he does. Why not have it more positive about, did you know, like not scary photos because we'll switch off that, but did you, I mean, we're there, we want to get better, we want our partner, whatever, to get better. Did you know that if you gave up smoking, whatever your percentages were, like turn positive messages into it and then talk about the quit line or whatever, and then also talk to us about it or talk, yeah.
Thank you so much. Would you give her a round of applause? That was a great suggestion. Very quickly, Sandra.
So I think ask is really important, but I think having somebody to coordinate this activity across the hospital is incredibly important.
Okay. One, it's got to be quick, sir.
Everyone needs to understand that the best way you can try and improve your cancer treatment as a whole is to try and quit smoking. Everybody in the community and providers need to understand that. That's the first step. And from that, everything else will matriculate.
Do you feel stimulated and motivated? That was a really limp response. Are you going to lobby the powers that be? Please give a big round of applause with stamping to my panel. And music will play when it's time to go to your next session, and see you this afternoon for a very lively rapid fire session. Thank you.